Acute management of spinal cord injury, early pre-hospital recognition of injury, prompt sedation, stabilization of injury, avoidance of additional neurological injury and medical complication. Initial evaluation ATLS, primary survey, airway maintenance and spinal vehicle, spine control, breathing ventilation, circulation with hemorrhage control, disability, neurological status, exposure and environmental control, completely undressing the patient while preventing hyper or hypothermia. Secondary survey head to toe evaluation, spinal immobilizations, rigid collar, backboard, quick motor examination, grip strength, foot dorsiflexion evaluation, gross sensory examination, signs of incontinence, urinary retention, signs of urinary incontinence and urinary retention, bone graft, autograft. Resuscitation begins during primary survey evaluation. Airway and breathing, oxygen delivery, chin tuck, jaw thrust, airway suctioning for blood or secretion. 3. Extrication and transportation, scoop stretcher, 4-person log rolling technique. Acute medical management में hemodynamic stability, prevent aspiration, minimizing the neurological damage caused during the primary injury, maintaining spinal immobilization until definitive management is accomplished, preventing further injury to secondary to hypoperfusion, ischemia, biochemical and inflammatory changes, maintenance of BP, prevent an neurogenic shock treatment due to sympathetic denervation, characterized by hypotension and bradycardia, restoration of intravascular volume, vasopressor agents, core temperature monitoring, NG tube to prevent emesis, aspiration of gastric contents, Foley's catheterization, referral to spinal injury specialized center. Once stabilized medically through CNS, X-ray, cervical spine, MRI, surgical management, surgical decompression approach, anterior approach, most direct decompression of spinal cord, anterior column restoration, potential complication, injury to recurrent laryngeal, injury to pharynx, esophagus, mediastinal or fistula, requires entry to chest or retroperitoneum, risk of respiratory complication and vascular injury. Several regions of the spine are inaccessible to repair via anterior approach. Posterior approach easier, less complication, although decompression of spinal cord might be indirect. Spinal hardware, plates, screw cages, bone graft to ensure future spinal stability, spinal orthosis to immobilize spine to facilitate bone fusion for 3 months post-operative, and pharmacology में MPSS, that is methylprednisolone sodium succinate high dose, methylprednisolone sodium succinate within 8 hours of the injury. The loading dose is 30 mg per kg over first hour of administration, and then maintenance dose 5.4 mg per kg for next